The biggest challenge is assuring the quantity and quality of the cells that you're getting doing it that way. And so I think the majority of the time, the risk should be pretty low. Most of these therapies seem to be pretty safe, but like.
Welcome to the Purr podcast, your favorite feline-focused podcast, where we dive into all things feline, medicine, surgery, behavior, and of course, a sprinkle of veterinary gossip along the way.
I'm Dr. Jolle Kuppenstein, feline fanatic, surgery nerd, and self-proclaimed lover of all things awkwardly cat-related.
And I'm Dr. Susan Little, proud cat vet, podcast enthusiast, and your guide to the wonderfully weird world of feline medicine. Let's get started.
Hello, this is Dr. Jolle Kuppenstein.
This is Dr. Susan Little.
Okay, we're now at 98.3%.
Yeah.
Of missed intros, Dr. Susan.
You do that after the
I did it 3 times, and you missed it 3 times.
Yeah.
How is that possible?
I thought you're going to... Okay, I got it backwards. Look, I haven't even had a full coffee yet.
Okay, this is the Purr podcast. That's what she's trying to say.
It is.
And we're very excited to be here.
And this is Dr. Jolle Kuppenstein.
Yes, I've already said that.
Oh,
but
did
you didn't say your name yet.
I'm Dr. Susan Little.
Thank you.
Yeah.
And we are in Anaheim,
Yes.
California. Very excited to be here for AVMA convention.
Yep.
We have a very special guest.
That's me.
That's you. That's not you. I'm glad it's not just me. That's you.
I'm Dr. Rebecca Windsor. I'm so excited to be here. I get to chat with you guys yesterday and love being here with you guys again today. So I am a veterinary neurologist. I'm also the vice president of veterinary affairs at Gallant. We're a company that's developing off-the-shelf stem cell therapies for pets. So excited to chat with you guys.
Very exciting. Yes. And this podcast is sponsored by an educational grant from Gallant. So thank you for that.
Yes, thank you,
That's awesome.
Gallant, very much.
Happy to support.
Gives us the opportunity to talk about some exciting new stuff that's in the pipeline. But first, we want to talk about you.
Yes, me.
What's your story?
Yes.
Yes. So, well, I did my vet school at UC Davis and then went to NC State for a year for my internship, then back to Davis for my residency, and then practiced for...
And residency in what?
Oh, neurology, neurosurgery.
Neurology.
Yeah.
I would love it.
Yeah. And yeah, we joke that we like had to hop and try every time zone until we settled in our current time zone. My husband's a veterinary surgeon, so we lived in DC for a couple of years. We lived in the Bay Area, Chicago. We have both of our kids in Chicago, which is where I'm from.
Okay, wow.
So I have a surgery question, but I don't have to do it now, but if you're ready, because there is always a little bit of tension between neurology, neurosurgeons, and surgeons. When the vet comes in, who does the surgery?
The neurosurgeons do it. So I've been very blessed to work at practices where they understand the appropriate way to do things.
Right.
So the neurosurgeons do the neurosurgeon, unless for some reason we're on vacation. Or
Exactly.
And then you can pick up the
because I think the rule was the neurosurgeons do it during the day until 11 p.m. and then the surgeons can do it.
I like that rule. I never abided by that rule. That sounds like a better rule than what my life was. I was just there.
Exactly. So we have solved this problem.
And your husband's a surgeon, like soft tissue, orthopedics.
He does everything. He likes ortho, but
Okay.
Yeah, and then we live in Colorado now. We were at Wheat Ridge Animal Hospital. I just left about a year ago to join Gallant.
Okay. Yeah. So how does a neurologist end up with a company that, as we're going to talk about, is interested in stem cell therapies? How does that happen?
Yeah, I always feel like just very fortuitously for me, it's weird how your life and career goes in different directions and you end up somewhere you never thought you would be. But so I have a really strong interest in neuroinflammatory diseases and trying to find ways to treat them better. You know, historically, really our only option is to suppress the immune system, and a lot of side effects and not always super effective. So so I work with a group called Ethos Discovery. I don't know if you guys have heard of them.
Ethos.
Yeah, solid research organization. So I lead their neurology research portfolio. So so one of my main interests has been finding ways to try to identify an aggressive type of immune-mediated encephalitis. It's called pug encephalitis in the pug breed. So I said the D word. I won't say it again.
Oh my!
I had to say it once because it's
okay.
But so we started using stem cells in my
I do like California wine though.
Yes.
So it's all good.
Okay,
You
just
can say as many D words as you want.
Write down what you need. I'll send
All
it
right.
out. So
That's a tough encephalitis. That's right.
It's devastating. I mean, it's rapidly progressive. It's very similar to a very aggressive type of MS in people. And so that particular subset of dogs is a good model for humans. And so we started using stem cells. And I'll be perfectly honest, when I first started that project, I had no idea what to expect. And it's such an awful disease. I wouldn't say that I didn't have a lot of hope, but you just don't know, right? And so I was just astounded by how quickly my patients got better after stem cell therapy. I'd never seen anything like that before. And so I found that I just started becoming so interested in that realm, and then was going to kind of transition into a greater research role over time. And then I just got this opportunity to come work at Gallant. And it's interesting. I never thought I would shift into industry. I love being a clinician, but it was just something I believed in, a company I believed in, and so it's a good opportunity to continue to grow and learn. And now I basically have to know a lot about things that aren't my specialty. So dentistry, orthopedics, dermatology. So in the beginning, it was kind of overwhelming because I felt like I was cramming for boards that were not my boards, to learn it. But we
all remember that feeling of trying to pass something that's not in your specialty.
But I think what's cool, what I've learned so much is that, even though we might focus on a specific specialty, so many of these diseases are really integrated. Much of the underlying disease mechanisms are really similar.
We don't traditionally, medicine doesn't integrate things very well. I think it's a very recent idea, right? To think of integrating things, right? Because, you learn dermatology is separate from the immune system, which it's not, right? Which is separate from orthopedic diseases, but it doesn't really work like that.
The integration of chronic inflammation has not been good. So people are either you're focused on the GI tract or you're focused on the bladder, but we know that it has all to do with the same thing. It's all connected. So
and I think part of it has just been the frustration of not having good tools, right? To help with these chronic inflammatory process. As you say, what do? We try to sort of very generically and globally, suppress immune responses. So looking at something like stem cell therapy has obviously it's been of interest in veterinary medicine for a long time, right? Because I know it's been there's been research projects looking at it in asthma and
so many things,
right? And so many other things. One of the things that I want to talk about is that stem cell therapies, once it got possible, I'll say possible, to do it in a clinical practice, we did see some companies kind of appear, right, and start encouraging veterinarians to do it in their own practice or that. And so I just want to get your take a little bit on that because it's almost like it I don't know how regulated is that?
For sure.
Oversight? Like, should we be doing that?
For sure. So, and we oftentimes kind of refer to kind of that way of doing things just for simplicity's sake, like the old way versus the new way, right? So a lot of people are very familiar with this old way, you know, and historically what was the only thing available would be to try to get tissue from the patient, and you would typically going to be fat that you would harvest. And there are some like in-hospital kits, for fat or bone marrow. There's some places you can send out. I think the biggest challenge is assuring the quantity and quality of the cells that you're getting doing it that way. And so I think the majority of the time the risk should be pretty low. Most of these therapies seem to be pretty safe, but you may have no idea if you're getting 1,000 cells or versus our products use 5 to 20 million cells. And so and there's a huge variability in the potential for what the stem cells can do based on the quality of the cells, right? And so so a lot of these older methods, it's just really difficult to predict and to be able to control that. And so because of that, we have to some degree a little bit of, I wouldn't say negative, but hesitation kind of around stem cell therapy because people associate it with this laborious way of doing it.
Yes.
Where the patient had to go under anesthesia and it's expensive, right? You're creating one therapy for one patient. That's typically thousands of dollars to do that. And so we're having to combat a lot of that now. Hey, this is actually really pretty cost effective for most people. The patient doesn't have to go through any procedures. And I think most importantly, you're able to develop a product where you can say, I know exactly what this is. I know exactly how many cells there are. I know exactly how they're working. And so, but to your point, people did kind of glom on to the excitement of stem cell therapy, and it created this environment where people were getting products out there that weren't really very well characterized, and then the problem is, because you can kind of say different things and label different things, they kind of all got termed to kind of be stem cell therapy, where like many of them might not even have stem cells in there. You don't know how many there are or how they're working. So what we always kind of try to advise people is just be really well aware of what you're using, right? And just, if you're going to try to use a product, not saying something's good, something's bad per se, but just make sure that they've really well characterized what's going on with that particular product for that particular condition. You know what I mean? Versus like, hey, try this on anything. And so that's why I think it's really important, as with all other things, that we need to have everything based in really sound evidence-based medicine. We've got to have good controlled studies to actually prove that these drugs are safe and working how we want them to work. So
can I do, before we go for really deep dive already, I want to take a step back and say, okay, what is a stem cell?
Oh, yeah, good.
Yeah. Thank you. Yeah. So basically, stem cells are cells that we all have in our body, pretty much in every sort of tissue. And their job is really to help support the repair and regeneration of tissue. So when your body is healing naturally, it's because natural stem cells in your body are helping to heal, right?
Well, they're there all the time.
They're there all the time.
They're doing their job all the time.
Yeah, they're doing their job all the time. There's different types of stem cells. The cells that people are typically using for therapies are called mesenchymal stem cells, or mesenchymal stromal cells is kind of the more appropriate term. And so you can get them from different tissues and kind of concentrate them down. But what's so unique about them is not necessarily the tissue that they're going to form as much as the way that they can modulate the immune system. And so one of the main ways they work, in addition to rebalancing some of those immune cells that you have in these disease states, is they essentially communicate with the other stem cells that are there. So when you have the chronic disease states, you got, in addition to like a really big imbalance of your pro-inflammatory cytokines and cells, et cetera, also your resident cells aren't working very well, right? And so whether that be resident cell, like let's say OA, for example, like your resident chondrocytes are not working very well, neither are your resident stem cells. And so the mesenchymal stromal cells can come in and communicate with those cells and help them to be able to function better. So it kind of promotes this repair by kind of orchestrating that environment.
And as I understand it, I mean, you have universal stem cells that can do anything in the world, but this is one step lower.
Yes, exactly. And so kind of the kind of big categories, I kind of think of three main categories. So one is called pluripotent stem cells.
Pluripotent, right.
Pluripotent meaning they can form any cell in any germline. They can form an entire organism. And those are being used to some degree experimentally. Historically, they came from embryos. No one really does that anymore.
Yeah, because they're not hard. They're not easy to get.
No, and it's not really ethical to do that. You know what I mean? So a lot of people have a time conceptualizing that. So that's pretty uncommon now. But if you look back to old literature, that was one of the main sources of those types of cells. The difference with those cells is they have a lot more ability to form new cells and form new tissue, which maybe can be good if you're wanting the cells to directly regenerate, but maybe can be bad, right? There's a higher risk for forming tumors and having the cells not necessarily do what you want them to do. And so, so they're used mainly experimentally, but look at people, for example, there are no FDA approved stem cells. They're a lot harder to control, a lot harder to get regulated, high risk, right? And so most of the cells that we're using are in this multipotent set below that. And then we have even below that, I call them unipotent. It means they just stick to their own lane. They can form themselves. Those are mainly the cells you're using to communicate, with other cells. But sometimes they will use those for like brain diseases and stuff, for example.
Because they're more targeted, I'm thinking,
like neuron types of cells.
So a bit ago, you said the word drug. So are stem cell therapies considered a drug? Are they FDA regulated?
Yep, they are considered a drug. And so, and they're a whole new drug category. Which is really exciting. So, and what's really cool is we're really not too far behind people. So they just had the first FDA approved human MSC therapy in the end of 2024. And so,
and for what was that?
That was for steroid refractory graft versus host disease in children. And so they've had that going on, but we're not too far behind that, which is really exciting. So, and that's another condition, really, really aggressive, few treatment options, kind of similar to what we're doing with refractory FCGS, and taking a really, really bad, condition and kind of starting, there. So, but yeah, we're on target to have conditional FDA approval for that product by the end of the year. So that's only 2 years, after.
That's amazing. That's amazing. Back again.
Gallant is an animal health biotechnology company creating a new category of veterinary care with a pipeline of off-the-shelf, ready-to-use stromal cell therapies targeting the root cause of disease in pets. Led by pioneers in veterinary regenerative medicine with deep expertise in development, manufacturing, and commercialization, Gallant is making regenerative medicine accessible, moving beyond symptom management to restoring health at the source. Learn more at www.gallant.com.
I know this one. I know, right. So we have these mesenchymal stem cells. Because that's not the only group of cells we have. We have also stem cells from other parts of the original body, to say. Why did you choose the mesenchymal ones and not the endodermal ones or the ectodermal ones or whatever stem cells?
Yeah. So it's again because of that potential for the immunomodulatory capacity within that particular cell line.
So the other ones don't have that?
Not to the same degree, and so they're less well characterized. Sometimes to some degree too, it's harder to get those from those tissues, so a lot of those are going to be like getting from a lung or getting from versus the mesenchymal stromal cells are a lot easier to access.
They're a little bit more generic.
Yeah, and they're kind of that trouble. And then most of the diseases we're trying to treat are stromal diseases, they're tissue diseases, right? So we're trying to promote regeneration within that tissue. And so like if you look at osteoarthritis, for example, in order to be a mesenchymal stromal cell, you have to be able to form chondrocytes, right? So that's a promising thing if we're trying to treat osteoarthritis. So they're really kind of focused on when they do regenerate within the tissues that we're typically targeting. So
right, so it has to do with the targeting the tissues too. So and then you said something about communicating. What do these cells do exactly?
Yeah, so they well, I will say this is what we think they do. We've got a lot of good evidence in vitro, mainly to see what they do. But essentially, they read an environment, and although they're usually going to shift things to be anti-inflammatory, they can go the other way. Like they're not programmed. So like if you put them in the body, but typically when we're treating them, they're going to get to, let's say you're treating atopic dermatitis, for example. That's a disease with very well characterized abnormalities in inflammatory markers and T cells, et cetera. And so they're able to get into that particular environment, read that environment, and then kind of work on those cells to reset things. And that's largely through secreting cytokines and growth factors themselves. The other big area of interest is they secrete exosomes or extracellular vesicles, which are like little, they're basically little enclosed blebs that come off the cells, and they contain proteins and lipids and RNA and DNA, and they use those to communicate. And so some people are exploring just looking at the exosomes and stuff too. So, but it's basically through secretion of those and then their impact on the other cells. And so we've been able to characterize pretty much for every immune cell you can think of, they're acting on those cells to rebalance things. And so, and that's why it's funny kind of coming back again to the similarities between diseases is that they tend to work in a really similar way.
No matter.
So then when you look at how they're working for each disease, you're like, they're really doing kind of the same sort of thing in every disease process. And so if you have a patient that has multifocal immune things, which I don't know if you guys have noticed that over there, I have noticed more and more, that they seem to be, they have IBD and atopy and OA and encephalitis.
I don't know if it's becoming more common. It may well be, but I also think veterinarians are tying things together that we didn't tie together before.
Understand it better.
Yes. Especially too with all the interest in the, gut-brain axis, the microbiome, the influence of the microbiome on everything. That's really helped drive things forward, I think, for people to really understand like the whole being type of inflammatory condition that we're dealing with a lot of humans too, you know what I mean, in patients. So that's really helped.
And with cats, we always say you get a whole bag of diseases. In the beginning.
Yeah.
The whole collection.
I know. So I know we're trying to target those most common ones first.
So that currently you're targeting the gingivitis, stomatitis, the chronic inflammatory. Why was that picked?
So we chose to target refractory FCGS for a couple reasons. One is that we had some really good research that really set the basis for that. I'd say one of the issues to some degree with stem cell research is like everybody's kind of all over the place and they're like different protocols, different doses. I did 3 cats and then 4 cats. So, this was a disease condition based on the work with the team at UC Davis that they started, 15, 20 years ago and really set the stage for this condition. So that was kind of number one, is we knew that we're kind of being able to join a body of work that was really solid. The other is that, as we kind of spoke about yesterday, this disease is awful. We just don't have good treatment options. And so we're really trying to target things where there's a big unmet need of like, how can we help the most cats? What are the most debilitating conditions, both for the cats and the cat parents that we can try to target first. And so that was one of the main reasons.
And you said that acronym really, really quickly. Can you slow that down a little bit?
Yeah.
What disease are we exactly
I have to say the
about?
acronym because it's so hard to say them out.
I know.
Yeah. So feline chronic gingivostomatitis. FCGS. Yeah.
FCGS.
Yeah.
Okay,
Yeah.
that's
Or you
easy.
could say stomatitis. Sometimes I say stomatitis.
Yeah.
Because it's easy to say.
And what, I mean, I think most of our cat loving veterinarians will know this, but what is this disease? Is it debilitating for the cats? What can you tell a little bit more?
Yeah. I mean, I think in general it's debilitating for the majority of them. So, it's super common. About 10% of cats are going to have this condition, and it's variable and it can be tricky because I think there's a continuum with other diseases. It's hard to diagnose, and I think the classic things with these kitties is they have these lesions at the back of their mouth, right? So ulcers, masses, and I think oftentimes they're misdiagnosed as being periodontitis and just pure gingivitis for a while because people aren't always opening and really looking in the back of the mouth of these kitties.
It really is stomatitis, which means whole mouth inflammation. And you're right, like the fauces at the back, right?
Yeah.
Is as a telltale sign.
100%. And oftentimes if they're painful, unless you're having them anesthetized, you're not really seeing that.
Yeah, that's true. That's true.
So I think for that reason, and because cats can mask their symptoms so well, they will eat through anything.
They will.
Is that we don't really know what's going on sometimes for a while. And so we know we've learned a lot about it, which is great. We know a lot of risk factors. I don't think it necessarily can help us from like not having them have those risk factors. We just know what they are. They're things that are most common. But I think understanding more and more, this immune dysregulation both in the mouth and systemically that is really driving it. So no matter what starts it, that's propagating in. And I think, certainly we can get a lot of cats better by, removing some or all of the teeth, but then you just have this big category of cats that is
don't
not
respond.
Yeah.
Yeah. And so I think it's a complex disease, right?
Very complex.
You mentioned that there's a number of risk factors. Whether there's cause and effect with all of the risk factors, also hard to know.
100%.
Right? And for each individual cat that has it, their sort of mix of etiologies or inciting factors, if you will, can be a bit different. But I guess the end result is the same. Right.
The end result is the same.
Right.
And what we've kind of theorized probably is, if there's this subset of cats that gets better, then maybe it is that you are removing that inciting trigger, whether that be viral load or bacterial load, and, readjusting a dysbiosis, and that's all they need. Whereas some of these other cats, I think their immune system has just taken over and it's just a disease in of itself.
That's a good way to put it.
Driving it. So that's why removing the teeth, antibiotics, antivirals, like they just don't work as well because you're not really treating the actual perpetuating cause of the disease.
So it goes a lot of that still dentals on cats. What do they look for?
So I'd say the number one thing to look for is these lesions at the back of the mouth. So if you're not seeing either ulcerative or proliferative lesions to the point like they can look like tumors. I mean, they can be enormous. I mean, once we've seen, we're like, there's no way that could just be a stomatitis lesion and then they can resolve, so
do you biopsy them?
You should 100% biopsy those. So we definitely recommend if you see those, to biopsy to make sure that it's not a squamous cell carcinoma.
Another one of the giveaways is that it's usually bilateral. Right. It's uncommon to see it. When I see something that looks proliferative, that's unilateral, I'm way more suspicious that it could be neoplastic, right? But almost always this is global and bilateral.
Right? Age difference between like squamous cell and this disease?
So most commonly we're going to see it in middle-aged, cats. So like if you had like a 3-year-old cat probably, but you just never know. I feel like young kitties get squames.
I think it starts, I think the stomatitis issue, this is just my opinion, I think it starts when a cat is young, right?
Recognize it when they're
but then I think, it's progressive, right? And so like a lot of diseases, especially in cats, I think by the time as veterinarians we recognize and diagnose this, it's been there for a while.
100%.
Right?
Yeah.
It's well established.
Yep.
And I think that's one of the reasons why treatment with antibiotics or antivirals only gives you brief success.
Yeah.
Right? Because the conditions, as you say, it's now become a disease unto itself.
Yeah. And it's hard too, because as we know, with chronic damage to tissue, like it takes a while to catch up and try to repair that, especially if it's been going on for a really long time. You know, we don't always know, to some degree, is some of that tissue permanently damaged. Like, so I think we see this discrepancy oftentimes, and how much better that a lot of them will feel. Like you'll have a really good percent of the cats feeling a lot better, like going back to pretty normal, you know, but you might not see the lesions go away, you know, and whether it's just that it's taking more time or just that there's some degree of permanent change to the tissue there.
I really like the fact that you emphasize that people biopsy, because I think it's a really important thing.
100%.
So what kind of results do you get back if this is the disease?
So it's lymphoplasmacytic inflammation, basically. Yeah. So if you get a good, you know, chunk of biopsy, you should be able to differentiate it. So,
just use one of those dermatomes to take a little biopsy.
You can, if they're very proliferative, you can often just take like your hemostats or like small scissors. Like I borrow the iris scissors.
Yes, that's what I was thinking too.
Right, because we have iris scissors, but we don't do any like ophtho. So I use the iris scissors, and you can just snip off a piece.
Yeah,
it'll bleed for a while, but it is what it is.
If I steal the neurology equipment, my head gets cut. If I steal the ophthalmology equipment, the same thing.
Yes. Yeah, well, we have iris scissors, but not an ophthalmologist. So who cares?
Yeah, we had to get our own iris scissors. Yeah. No, but that's, and oftentimes they'll do it like if they're doing a dental, like getting a biopsy and stuff.
Yeah.
So we will be talking about a fantastic therapy that's coming on the market. It's on the market, but that will be the next time, because we're almost at the end.
Yeah. The cliffhanger.
Yes.
This is the cliffhanger.
Stay tuned.
Episode, because it's so exciting. Because the thing what I think is exciting, and this is something that we talked about in our last podcast too, is that lately in cats we've had so many breakthroughs. And that makes it super exciting, because before that, and we have been doing this for the last 9 years, before that we were rehashing the same things and the same therapies, and
looking
the
for sort of
frustration.
incremental.
I know.
Yes.
Now
And
we're
now all of a sudden,
crazy. And
these are once in a career type of things.
Yes. And very intentionally chose cats first.
And that's the thing, you know, this is a company that only focuses on cats right now. Maybe later the D
word.
That's okay.
The cats are
as long as they're front and center right now.
That's what we want. So we appreciate that. So yeah, this has been fantastic. I'm very excited to hear about the second part. We already talked a little bit about stem cell therapy. There's a lot of questions left.
Yes.
So we'll do that in the next episode. But this has been fantastic. Thank you.
Yes.
Thank you.
Yeah. Thank you.
This is the Purr podcast, where we talk cats, laugh a lot, and learn something new every episode. Together, we bring you the latest updates, surprising cases, expert interviews, and just a touch of chaos, because nothing with cats ever goes as planned.
So whether you're a seasoned veterinary pro, a new grad, or you're just here for the cat puns, you've come to the right place.